Hi, my name is Sam Most, and this is the 7th short video describing one of the chapters in my new textbook, Comprehensive Rhinoplasty Structure and Preservation Concepts. It's the first textbook describing structure and preservation, and I'm very excited about it. It has received very nice reviews, including a 5-star review from Aesthetic Surgery Journal. It's available from Quality Medical Publishers. And so let's dive into Chapter 7, which is dorsal hump reduction. And of course, this is an exciting area where there are worlds colliding with regards to conventional hump resection and dorsal preservation techniques. And this chapter describes conventional hump resection. And so dissatisfaction with the profile view is one of the key indicators for rhinoplasty. And this has been shown in multiple studies, including from my group. And one of the keys to understanding this is the fact that you have to really know when you're looking at a patient whether they have a hump or not. You have to look at whether the projection is appropriate and whether the radix height is appropriate, and also talk to them about what sort of contour they're looking for. There's a lot of emphasis in social media on things like pixie noses and princess noses and so on and so forth, which is not necessarily the best for every patient in the long run. So it's usually not something we recommend, but everyone has their preferences. It's really important to understand what you can do for the patient safely in the long run. So understanding the anatomy is really important, and there's a whole chapter on anatomy. We briefly overview some of the salient aspects in this chapter. And I think one of the important aspects for understanding dorsal preservation or conventional hump resection is the quadrangular cartilage, the extent of the quadrangular cartilage, where the ethmoid point is, which was described by Miguel Ferreira. It's the posterior superior point of the quadrangular cartilage. Understanding the dorsal key area anatomy, the lateral key area anatomy, the fact that the upper lateral cartilages extend underneath the bony cap, as does the septum. And so understanding all of this helps you in your evaluation, A, for whether patients are good for conventional hump resection or whether they're good for dorsal preservation, and also how you're going to approach those patients. So let's talk about conventional hump resection. So classically, a composite reduction of the dorsal hump is described using a Rubin osteotome as shown in these diagrams. And I think this is probably the least controlled way of doing this. Of course, some of my colleagues who do this all the time may disagree. But generally speaking, controlling that osteotome, even if it's sharp, and making sure all the cuts are even is somewhat difficult, although it does look really cool when it works. I will say that this is not something that I regularly really ever did. Component resection is more commonly something that I did perform, and I still do in the right cases, and that is essentially some sort of variation of what you see here, whereby you release the upper lateral cartilages and rasp the bony vault, creating an open roof, do your dorsal septal resection, and then perform osteotomies. And then, of course, subsequent to this, you need to perform some sort of mid-vault reconstruction in 99.9% of cases, and that can involve spreader grafts, shown here in green, or autospreader flaps or spreader flaps, depending on which terminology you like. It's essentially the same thing, which is folding the upper lateral cartilages in, whether you score them or not, or whether you do dissections of the mucosa. Those are the variations that various authors have described. But this sort of reconstruction is necessary in the mid-vault to prevent an inverted V deformity, internal valve narrowing, and collapse of the airway. And so that is how we approach conventional hump resection. One of the things which is really nice with the piezoelectric instruments is that we can actually create small drill holes in very controlled fashion, even in mobilized nasal bones, and use sutures as shown here to narrow the bony vault. As I mentioned in my last video on the last chapter, one of the most common problems I encountered was not overmobilization, but undermobilization of the nasal bones, or leaving an open roof. I think that was out of fear of the complication of overmobilization. But with piezoelectric instruments and the suture control of the nasal bones, we can actually be more aggressive with narrowing the bony vault and creating better dorsal static line contours in these patients. So this is a patient who underwent conventional hump resection. This is 7-year postoperative views, including frontal views and side views. This is 2-year postoperative on a large nasal hump not appropriate for dorsal preservation, showing the techniques that we used in this patient. Here's another one with standard conventional hump resection methodology with autospreaders performed in all of these patients, spreadographs in addition in some patients. What are the complications that can occur? One of the most common is a polybeak deformity. These are patients, by the way, who came to me from other surgeons for correction or revision rhinoplasty. The upper diagram shows a patient with polybeak deformity. The lower diagram shows a saddle nose, which is also one of the things which can occur. And this is, of course, a very severe one, which required rib graft reconstruction. So the key points are that dissatisfaction with a profile view is the most common reason to seek rhinoplasty. And you can reduce the hump through preservation or resection methods. This chapter described resective methods. The important points are measuring exactly how much you want to remove, mobilizing the nasal bones appropriately to close the open roof without creating overmobilization. Mid-vault reconstruction is the most important aspect of component or composite reduction, and spreadographs and autospreader flaps can both work. And I think the piezoelectric instruments have really revolutionized the way we perform this operation. And in the chapter, we go into detail about all of these points. And this was just a really brief overview, and I hope you enjoyed it.